Thank you very much, Mark. Some of this is a bit advanced, and there's a few pictures. There's a little video here of an operation, and there's a few pictures of actual tumour surgery. You may or may not want to see it, or if you have any questions as we go along, just put your hand up. We'll keep it informal, because I accept that actually there's a mixed audience here, but whoever wants to ask a question, just do so. So, 400 or 500 new brain tumours a year. There's 15 neurosurgical units in the UK that can offer neurosurgery for children, and there's about 50 paediatric neurosurgeons in the UK at the moment, and that's changed over the last 10 years. About 10 or 15 years ago, there was probably 8 to 10 paediatric neurosurgeons, so those numbers have mushroomed. And there's a lot of national discussion regarding centres for neurosurgery, the safe and sustainable process that some of you may have been engaged with. And really, it's looking at the standards that are offered. Has everybody got the same standard of care across the UK in each centre? Volumes of cases, staffing, on-call, is there 24/7 cover, equipment and outcomes. And although there's been a difficult political process in the last 3 or 4 years, most of it, hopefully, is going to be a positive thing. It's been a painful process for the professionals, but one hopes that out of all of it comes proper outcome analysis, proper teams that are dedicated to brain tumour surgery. And I'm actually very positive that through the standards and outcome-driven measures, you'll all get a better deal long-term, and the children will. Just a little bit about background. Neurosurgery for brain tumours, it's not just about removing the tumour. Half of the cases, is there a pointer, by the way? There is. Half of the cases will present with headache. If we look at a number of different tumours and presentations, and that's because half of kids with brain tumours will get hydrocephalus, and that will manifest with headache and vomiting. But you can see there's a huge range of symptoms that can be experienced with brain tumours in children, and one of the recurring themes is, of course, getting the clinicians to take symptoms seriously and getting to scan and getting a timely diagnosis. And in fact, in this study by Wiln et al., this is the length of time before you get your diagnosis with different types of symptoms. For example, if you've got growth deficiency, it may be up to 2 or 3 years before you get your diagnosis if a tumour's caused it. If you present with epilepsy, it'll be about 10 or 11 months before you might get your diagnosis, looking at 200 children with different types of tumours. The commonest things, such as increasing head circumference in babies, is actually quite quick. But generally speaking, the delay to diagnosis in the UK is still significant, and it's still a problem. Now, what about progress? Well, this is a historic slide, but it looks at different tumours and their overall survival, and CNS means central nervous system tumours, and there's been a gradual improvement in survival, but not dramatic like some other things like AML or ALL. But in the last 10 years, there's been a lot of advances in neurosurgery, and certain types of tumours are doing a lot better, and this graph will continue, hopefully, to rise. But of course, other advances in chemo and radiotherapy have all got their part to play. Well, when we get a diagnosis of a child with a brain tumour, they're referred for further management. Often that diagnosis is done in the DGH. We have a multidisciplinary discussion. We refine the imaging. Often we have to repeat all the scans because of all the advanced imaging that's happening now. MRI, MRS, spinal MRI scans, staging of the tumour, consent for surgery, and now all patients are entered into biological studies as we go along. And then we do surgery. We do it to obtain a diagnosis, to relieve pressure if there is there. If we can, we do a complete resection if risk is acceptable, and we manage the hydrocephalus. At the end of all of that, we do another MRI scan to assess the extent of resection. And then we have another multidisciplinary management after histological diagnosis, biological profile. And then if we can, we enter into trials where appropriate. And that sort of gives you a snapshot of the process. And clearly, as the neurosurgeon, we are but part of a very, very big team. And these are all the sorts of people that are involved with management of brain tumours. And it is, of course, multidisciplinary. And I think probably the biggest advance for neurosurgery, despite all the technical stuff that I'm going to show you, is the fact that we as neurosurgeons in the past 10 years have engaged with oncologists and radiotherapists and all of the other team associated with it. And now and I'm sure the oncologist will say the same thing, the crossover between decision making that has changed in the last 10 or 20 years is really the major advance, and we're all talking to each other and listening, hopefully. So it is a meeting place between paediatrics, the needs of the high-tech community of neurosurgery, neuroradiology and neuroanesthesia. We have increasing demands, though, for evidence-based techniques. And everything that we do, for example, the technology I'm going to show you, costs a lot of money. And the numbers are very small. Your average unit you saw earlier might treat 10 to 20 tumours a year. And we're talking about £3 or £4 million worth of kit for things like intraoperative MRI scan. There's pressure to produce complete surgical resection. We're sending patients to proton therapy. And we need to make sure that the tumour is, if appropriate, completely removed. If not, places like St. Jude's and Florida will question any residual disease before protons are given. This is a good thing. It's important to establish extent of resection, and we're under increasing pressure to do so prior to giving radiotherapy, for example. Subtotal resection is also important, though, in debulking, important in symptom and disease control, and in managing the patient along their pathway. So it's not just about complete resections. So the main driver for change in neurosurgery, however, has been the developing of powerful imaging tools, computers, advancement in anatomy and physiological pathways. And that's changed quite a lot of what we do. And how have things changed? Well, 10, 20 years ago, the mortality from a brain tumour operation was much higher. Now, really, it's less than 1%, and we don't expect mortality from actually operating on children. We expect them to pull through every time. Things like dexamethasone have helped. Good PICU and HDU care, surgical techniques, the microscope in the 70s, ultrasonic aspirators, neuronavigation, which came in the sort of 80s and 90s, is now a standard of care, and I'll show you what I mean by that. Sat-nav of the brain is the sort of layman's term. Endoscopy is minimally invasive approaches have changed a lot of what we do, and in the way we manage hydrocephalus. And of course, intraoperative MRI is the latest thing, and I'll show you a little bit about that. So what about imaging? Well, what's changed? Imaging has changed to the fact that we can get to tiny little lesions with computer-assisted navigation that we just simply couldn't have got to safely in the past. And when we talk about imaging, we now want it not just to localize the tumour, but we want it to define the normal areas and tracts. We want to assess the effect on adjacent tissue, and we want to ideally predict how the behaviour of the lesion is going to be. So nowadays with spectroscopy, all those long MRI scans that these children are having, up to 1 hour of imaging, it's all about getting as much physiological, functional information as well as just what we used to just try and do, which was localise the tumour. And that helps us decide how we're going to operate. What about neuronavigation, or sat-nav of the brain? What does that mean? Well, that means that we acquire a volume, a data set with a CT or an MRI scan. Usually it's an MRI scan. We then make a 3D model of the head by registrating to the surface. So we use a special technique where we touch the surface of the skin and make a model of the head, making a map, essentially. And then software from the computer marries that volume and basically creates a pointing device so that we're inside the brain, we can point to tiny little lesions that we're trying to target. So this is the 3D volume that is made, and we're looking to try and get this small lesion out of the brain, and we can use a pointing device because once you're inside the brain, it's very difficult to find. This is a recurrent tumour, which was a small little lesion that had come back after 5 years. And clearly, if you went in there deep without any navigation, you would struggle to find that lesion. And this is us going in and picking out that lesion. This is the pointing device telling us that's exactly where we are. That's a real image. That's me pointing at that lesion, and that's us removing it. And that's how navigation has changed. And that's become a standard of care in the past 10 or 20 years. There isn't a unit in the country now that doesn't have navigation. 5 years ago, quite a lot didn't. What about other things, minimally invasive surgery? Well, endoscopy has changed a lot the way we do. In the old days, there was only one treatment for hydrocephalus, and that was a VP shunt. Now, we can put a little endoscope in and make a tiny little new internal bypass, and this allows the fluid to escape, bypass the tumour. That's where the tumour is blocking things. This allows the fluid to come down a new pathway and allows us to avoid putting shunts in. And we tend to do that preoperatively now for children with hydrocephalus if there's a big tumour obstructing the pathways. We also do endoscopy for managing biopsies. We do it for draining cysts, such as craniopharyngioma cyst. This is a cystic tumour, and other types of biopsies, and third ventriculostomy as shown. I'd like to tell you a little bit about intraoperative MRI because a lot of units are beginning to look at this as a new way forward to help with imaging and managing patients. Well, some of the things I showed you about neuronavigation are limited. Surgery is based on a preoperative image, so it's a bit like driving a car to an old map that's 10 years old and they built a load of new roads. As you operate, things change. So as you move bits of tumour and as you're operating, your pointing device is working to a preoperative image or map. But clearly, as you begin to take tumour away, things move and your scan, your navigation becomes inaccurately. So this leads to brain shift and inaccuracy, and in fact navigation becomes dangerous. So once the tumour is partly removed, we can no longer refer to the scans and we can no longer rely on the navigation. So intraoperative MRI has been used to update the images as we go along to make a new map. And so what we really want is to, with intraoperative MR, update our map, but we also want a complete package at the time of surgery. Why should we wake a child up and then wait 24 hours to find out if we did what we wanted to do? Why shouldn't we be able to tell at the time of surgery that we have done what we, why shouldn't we be able to come to you and say, I've done the operation, I've done exactly what I wanted to do, here's the MRI scan, and this is exactly what, we don't need to do anything more. So that's what intraoperative MRI offers you. It offers you the verification of the extent of surgery. And it gives you options for subtotal resection to define tracks, functional imaging, and to make sure your surgery is as safe as possible, eliminating complications if possible. This is what an intraoperative MRI scan looks like in Liverpool. It's the first intraoperative MR scan in a children's hospital in the UK and indeed in Europe. It's just a transfer system between a scan that actually works as a completely normal MRI scanner most of the time. So while we're operating, they're using it as an outpatient scanner for general anaesthetics as appropriate. And why do and how do we use the scanner? Well, we use it for navigation, as we discussed, if we lose accuracy. We also use it for subtotal resection for deep-seated tumours. We tend to, when we do a very deep-seated tumour, remove part of it, do an update scan to assess where the important structures are, improve the safety, and then go back and resect as appropriate. And of course, we do it when we're surgically aiming to completely remove the tumour. We usually do a scan at the end to confirm that that's exactly what we've done, i.e. we've done complete resection, so we don't have any surprises the next day. Post-operatively, we'll always do a post-operative final scan. There's no need for a scan the next day. And we'll also do it after biopsies so that we can confirm that we've taken the specimen from the right place. Here's a little 2-minute video, just shows you a case, gives you an idea of what happens in surgery. So this is us planning a case, and this is how we use the navigation, and we import the images onto the computer screen, and we do some planning. This is a case of a recurrent small tumour in the pituitary gland. It's called a craniopharyngioma. And for this sort of surgery, another advance is we don't have to open the head. We can use an endoscope and go through the nose to get to this. This is the MRI coil. These are the cameras that track the pointing devices. That's us registering the patient and creating the volume with a special laser. And this is us using the pointing device, checking the accuracy. And then this is us putting the coil for the scanner, just checking it fits so that when we're halfway through the surgery, we can put that on in sterile conditions and do a quick scan. This is an operation involving surgery through the nose, as I've said, and we just use an endoscope and we can get to the pituitary gland and places like that now with a simple endoscope without the need for open surgery, and that's a big advance in itself. And this is us discussing the route. This is our pointing device. This is where the tumour is. And once we've performed the surgery, you'll see in a minute the tumour is just being removed with a little special micro instrument. And this is the craniopharyngioma that was recurred. It's a benign type of tumour, and that comes out, and that's us confirming that. But once we've done that, we've gone to all this effort. We're going to do a quick scan, put the coil on. This is a sterile towel covering it. We just wheel into the scanner, do a scan, make sure that we've done exactly what we wanted to do. And this is the transfer. It takes about 10 seconds. You just disconnect and reconnect while the child is asleep. This is us doing the scan, checking that the pituitary gland is now clear and the tumour's gone, which it has done. Once we've finished, we go back in and we either do more surgery, or we close. And that's a 2-minute operation. That takes about an hour, that whole process. These are some examples where we've lost navigation. You can see swelling of the brain, and we're doing an operation to remove a thalamic tumour, deep-seated tumour here. And this is the tract, and it's going the wrong way, and we can't find the tumour. Clearly, that's not satisfactory. That's the inappropriate tract. So we do an intraoperative MRI scan, and then we remove the tumour along the correct navigation pathway. These are examples of intraoperative scans, a pineal tumour, which is very deep-seated. This is the intraoperative scan confirming complete removal. No need for further surgery, so we just close up. This is an example of a biopsy of a tumour, and here we just want to make sure that we catch the wall of the tumour where all the diagnostic tissue is, and this confirms the little holes. We do a quick scan immediately after the surgery. This shows that we've taken the biopsy from exactly where we wanted to do, so we don't have to come back another day because the specimen's non-diagnostic. We sometimes in babies get enormous tumours, and this is a 2-week-old child. And in this case, we just want to resect the tumour down to a smaller residual and make sure we don't harm an important area called the hypothalamus. But you can see as we do stage surgery, we do an intraoperative MRI to update, and then we do the final result, which is what we were aiming for. This is a tumour that we got from, this sort of shows the sorts of pressure we're on and how things have changed. So this is a tumour from another unit that was referred to me, deemed inoperable, put on palliative chemotherapy. Ependymomas, we know, don't respond very well to chemotherapy. They need to be completely removed. And the question was, can we remove this tumour because I've got an intraoperative MRI scanner? And the answer is, well, the scanner doesn't do the surgery, unfortunately. Can we do it? Well, it will take stages. But I think 5 or 10 years ago, that sort of tumour would have been deemed almost inoperable and would have been sent for palliative care. But instead, we did do it, and we did it in a few stages. And this is the intraoperative MRI showing a near total removal after 2 stages. We then sent that patient for protons. There's a residual area here that's a bit suspicious, and this is the sort of pressure we're under. They go to Florida for protons. They see a little tiny bit of lesion, and they say, guys, we're still not happy. We want you to remove every last bit. So came back, and we removed the final bit of that tumour. Here's the intraoperative MRI scan. Now, that patient, previously inoperable, has had a complete resection and protons and has a very good prognosis now. Other tumours that were sent to us felt to be inoperable and extensive. Big tumour involving a large part of the hemisphere. We do functional imaging to check where the tracts are, and if we feel that the tracts are away from the tumour, which we did in this case, then we can go ahead and remove the tumour completely. There was a bit of residual initially, and this is us resecting the last bit. More functional imaging, deep-seated tumours, thalamic tumours, midbrain tumours felt to be inoperable in the past. Functional imaging, decide on your tract. This patient, again, presented with a weak side, and this tumour was completely removed with further surgery and intraoperative MRI, and in fact the weakness improved. So using functional imaging, showing where the tracts are, we can decide what tumours are removable and what aren't. So 80 tumours, just a few results. 2010, we did 80 tumour resections with the intraoperative MRI, and we do further surgery after the first scan in about 30% of cases. Patients in whom we were aiming for complete resection, we did, again, 30% or so had further surgery prior to closure, and in partial resections, we improved the level of partial resection, if you like, and did further surgery in, again, about 40% of cases. How does that compare to pre-intraoperative MRI era? Well, this before the intraoperative MRI era, 2007 to 2009, where we were aiming for complete resection, we had residuals in 20%. 14, all these patients went back for further surgery at some point within a year. Similar numbers for intraoperative MRI. The difference is that they all had their immediate repeat resection at the time of the first procedure. No further resections within 1 year. And that is statistically significant. So it has had an effect. So conclusions with intraoperative MRI. So far, well, we change our plan in 30% of cases. The best thing about intraoperative MRI is we sit there with the radiologist interpreting the functional imaging, the tracks, and I certainly have understood much more about radiology through working with a radiologist, and I'm sure they have too, because they work with me, and together we interpret the level of resections. Has it benefited the patients? I think it has. I think we've shown that we don't go back to repeat surgery unnecessarily in the next year, and also it really is about quality. I have to say that since we've been using it, just to be able to go to the family and say, I've done the operation that I wanted to do, There will be no surprises. This is the final result. You don't have to wait another 24 hours, and we don't have to put your child back to sleep the next day for a repeat scan. Changes a lot, and it's just the quality, which is not measurable. The service you can offer the families is fantastic. The only way to be cost effective is to have two rooms working separately, and we've already talked about quality and safety. Summary. Surgery with complete resection plays a major role in survival for most tumours, not all, and we're going to hear about chemotherapy and radiotherapy, of course. It is becoming increasingly aggressive in its approaches. There's no doubt that what is possible now was not possible 10 or 20 years ago, and a lot of inoperable tumours are not actually inoperable with experienced surgery and all of the advanced functional techniques that we have. As surgeons, we have to have a responsibility to maintain the highest standards. We've got to keep up with technology, but maintain the ability to critically appraise new technical equipment. The NHS isn't going to give us equipment for free. The numbers are small. Most units treat 10 to 20 tumours a year. They're unlikely to give you 3 million quid for an intraoperative MRI scanner unless you can come up with a very good business case. And these are the challenges that we're faced with. But I'm sure that in 20 years' time, all operating theatres operating on brain tumours will have intraoperative MRIs. We have to accept our results should be scrutinised. That's been a big change in the last 10 years. 10 years ago, the surgeons had the last word. If we said the tumour was inoperable, everybody had to accept that. That's not the case anymore. Now, we send a patient for protons, it gets questioned. If we send the patient to the oncologist and they don't like the look of the residual disease, it gets questioned. And that's the way it should be. We shouldn't be the last word. All surgeons operating on brain tumours in children should be experienced and dedicated to the cause. It's not an occasional surgery just because you're on call, you inherited a child and you say it's your patient and you operate on it. It should go to the most experienced surgeon in the unit. There is a national process which I think is for the good, trying to improve standards. Surgical techniques and advances evolve all the time, and surgeons must be part of the MDT. Multidisciplinary working is probably the most important thing that's changed the way we work, because we all understand more about brain tumours. I think oncologists learn from us, radiotherapists learn from us, and vice versa, and that's changed in the last 10 years. We must always consider the long-term consequences. It's not, of course, just about complete resections. It is about the whole package, and it's about short and medium and long-term gains and survival, and all of those things clearly come into the equation. And I think that's all I want to say. That's my son. He doesn't care.